Hello students, in today's video we are going to discuss pharmacology of anti-rheumatic drugs, a complete comprehensive overview. Now before going into the pharmacology of anti-rheumatic drugs, it is essential to review pathophysiology of rheumatoid arthritis disease. Now rheumatoid arthritis is defined as a chronic progressive inflammatory autoimmune disease affecting joints. As we all know, rheumatoid arthritis is a chronic disease as it continues for a long time. It's progressive as it may get worse over time. Rheumatoid arthritis is characterized by inflammation and associated pain in the joints. Now look at this figure. It shows a joint affected with the rheumatoid arthritis. Now rheumatoid arthritis is an autoimmune disease because the immune cells of body like macrophages, T cells, plasma cells that fight against infections and protect our body start attacking healthy cells and tissues of the joints, causing joint swelling, pain and stiffness. Now let's quickly see to the signs and symptoms of rheumatoid arthritis. Now as we all know, rheumatoid arthritis is caused due to joint inflammation, and this results in joint swelling, pain and stiffness. The joints lose their flexibility and this impairs and restricts the movements. Now again look at this figure. This is a normal synovial membrane in pink, and this is a thick synovial membrane which is affected by the rheumatoid arthritis. So as rheumatoid arthritis is a chronic disease, if it is not treated, then joint inflammation progresses to articular cartilage destruction. This is the articular cartilage in blue. So this inflammation causes destruction of the cartilage, and this also damages the bone. So there is bone erosion. So rheumatoid arthritis results in joint swelling, pain, stiffness, articular cartilage destruction and destruction of the bone. And this can lead to joint destruction. There can be complete joint destruction or joint deformity and loss of function. And therefore the patient finds it very difficult or unable to move. So goal of anti-rheumatic therapy in rheumatoid arthritis is to reduce pain, swelling and joint stiffness, then to prevent articular cartilage destruction and also to prevent bone erosion, that is to prevent the destruction of bone. So anti-rheumatic therapy should aim at preventing the joint destruction, preventing joint deformity and prevention of loss of function of the joint. Now let's classify anti-rheumatic drugs. Now the first and the most important class of drugs used for the treatment of rheumatoid arthritis are disease modifying anti-rheumatic drugs or DMARDs. Now DMARDs interfere with inflammatory process causing rheumatoid arthritis, and unlike other drugs, DMARDs produce remission. Remission is a retardation or complete prevention of disease. So DMARDs prevent progression of rheumatoid arthritis, which is not seen with other categories of drugs. Now these DMARDs are also associated with potential adverse effects, and the beneficial effects with DMARDs is seen in few months after the initiation of therapy, and till that time patient can be given corticosteroids. Now these DMARDs are of two types: conventional or synthetic or non-biological DMARDs and biological DMARDs. Now conventional non-biological DMARDs include immunosuppressants like methotrexate, azathioprine, sulfasalazine, chloroquine, hydroxychloroquine, then leflunomide. Now biological DMARDs include tumor necrotic factor alpha inhibitors like etanercept, infliximab, adalimumab, then interleukin 1 antagonist like anakinra. Now these biological DMARDs these are also very efficacious. But these drugs can cause very serious or fatal infections. So the adverse effects with biological DMARDs are higher compared to conventional DMARDs. So these biological DMARDs are used as reserve drugs for severe refractory rheumatoid arthritis not responding to synthetic or conventional DMARDs. Now, apart from DMARDs, there are certain adjuvant drugs like NSAIDs for symptomatic relief. For example, ibuprofen, diclofenac, celecoxib, then corticosteroids. As we all know, corticosteroids are very potent immunosuppressants and anti-inflammatory agents, but these are used only for short term. These are used for the short term therapy because of their side effects. For example, prednisolone. Now let's discuss treatment approach in rheumatoid arthritis. That means how to treat rheumatoid arthritis. Now treatment of rheumatoid arthritis is divided into two groups. One is the acute inflammatory treatment and the other is long-term pharmacological treatment. Now acute inflammatory treatment is the treatment for a short period of time, and this include treatment with NSAIDs like ibuprofen, diclofenac. Now NSAIDs provide symptomatic relief. They cannot reduce or they cannot prevent progression of disease. Then glucocorticoids. Now corticosteroids are also used for short period of time because of their wide range of adverse effects, like for example osteoporosis, glaucoma, peptic ulcer. Now glucocorticoids like prednisolone is used orally, while triamcinolone acetonide is injected by intra-articular injection, that is directly into the joints. Now corticosteroids are anti-inflammatory and immunosuppressant agents. Now as we all know, rheumatoid arthritis has a waxing and waning course. So sometimes symptoms flare up. That means the intensity of symptoms increase. So glucocorticoids are useful during disease flare up when the intensity of symptoms increase. Secondly, for relief until onset of action of DMARDs, which takes around 6 weeks or more than 6 weeks. And as discussed, glucocorticoids are used for short-term therapy because of their side effects. After acute inflammatory treatment, long-term pharmacological treatment of rheumatoid arthritis is done by the use of disease-modifying anti-rheumatic drugs, that is DMARDs. Now, as discussed earlier during the classification of anti-rheumatic drugs, DMARDs reduce symptoms of rheumatoid arthritis. DMARDs suppress inflammation, stop damage to bone and cartilage, and most important, produce remission. That is, they stop or they retard the disease progression. And as discussed, these DMARDs are of two types: conventional or synthetic or non-biological DMARDs and biological DMARDs. So this is the treatment approach in rheumatoid arthritis. Now let's first discuss pharmacology of conventional or synthetic or non-biological DMARDs. Now before discussing pharmacology of DMARDs, look at this slide showing diagrams depicting pathophysiology of rheumatoid arthritis. Now as we all know, in rheumatoid arthritis, immune cells of the body attack healthy cells and tissues of the joints. So this figure shows healthy synovial membrane in the, this is a healthy synovial membrane in the pink color. Now this diagram shows thickened synovial membrane. So this is the thick inflamed synovial membrane in rheumatoid arthritis. Now in rheumatoid arthritis, immune cells like macrophages, T cells, plasma cells, they infiltrate and they reach the synovial membrane, while neutrophils, they are seen in the synovial fluid. Now activated T cells produce cytokines. So now look at this figure. These activated T cells, they produce cytokines, and these cytokines further activate macrophages, and these cytokines also activate B cells. Now activated macrophages produce cytokines like tumor necrotic factor alpha, interleukin 1, interleukin 6. Now these are the main cytokines produced by the macrophages. Now all these cytokines, they produce inflammation, and these cytokines are also responsible for the proliferation of fibroblasts like synoviocytes. So these fibroblasts are found in the synovial membrane, and proliferation of these fibroblasts causes thickening and swelling of synovial membrane, and there is formation of pannus. Now this structure called as the pannus, it is responsible for the destruction of this articular cartilage shown here in the blue color, and this pannus also is responsible for the destruction of bone. Now these fibroblasts, they produce enzymes like proteases, they produce enzymes like matrix metalloproteinases, and these enzymes, they destroy bone as well as the cartilage. Now these cytokines, they also activate osteoclasts. Osteoclasts are the bone breaking cells. So activation of osteoclast results in the erosion or destruction of the bones. Now T cells also activate B cells, and B cells further activate the plasma cells which produce antibodies like rheumatoid factor, and antibodies like anti-citrulline protein antibodies. These antibodies also attack healthy joints responsible for rheumatoid arthritis. Now most of the synthetic, conventional or non-biological DMARDs inhibit activation of immune cells, like they inhibit activation of T cells, thereby reducing generation of cytokines, thereby reducing activation of immune cells like macrophages, and inhibition of T cells, inhibition of the proliferation or activation of T cells also inhibit activation of B cells, further inhibit generation of plasma cells and generation of antibodies. So overall, these synthetic DMARDs, they produce anti-inflammatory and immunosuppressant action. On the other hand, biological DMARDs directly target cytokines like tumor necrotic factor alpha, interleukin 1. Now biological DMARDs destroy these cytokines or block their function, providing relief in rheumatoid arthritis. So this is how DMARDs, synthetic as well as biological DMARDs, they are found to be useful in the management of rheumatoid arthritis. Now let's first discuss pharmacology of conventional synthetic or non-biological DMARDs. The first drug is methotrexate. Methotrexate is anti-inflammatory and immunosuppressant, and it is the DMARD of choice. It is a first-line drug in the treatment of moderate to severe rheumatoid arthritis disease. Now let's study its mechanism of action. Now methotrexate inhibits enzyme aminoimidazole carboxamide ribonucleotide transformylase. Now this enzyme metabolizes adenosine. So inhibition of this enzyme inhibits metabolism of adenosine. This causes increased accumulation of adenosine, and adenosine produces anti-inflammatory and immunosuppressant effect by inhibiting activation of T cells. It causes downregulation of B cells, that is B lymphocytes, and also inhibit activity of interleukins. Interleukins are inflammatory cytokines. Now let's talk about the adverse effects. Common and the major adverse effects of methotrexate are oral ulceration and gastrointestinal upset. It produces bone marrow suppression, causing for example pancytopenia. Now, prolonged therapy causes liver damage leading to cirrhosis, increased incidences of chest infection. Now, methotrexate is teratogenic and produces fetal structural abnormality, and methotrexate also shows potential drug interactions with the NSAIDs and proton pump inhibitors. It should be administered only in consultation with a physician. Another immunosuppressant and anti-inflammatory non-biological DMARD is azathioprine. Now, azathioprine is not very efficacious and thus it is less commonly used. It is primarily used along with corticosteroids in rheumatoid arthritis. Now, as we all know, corticosteroids possess wide range of adverse effects. Now, azathioprine when used along with corticosteroids reduce dose of corticosteroids to minimum, and thus azathioprine is used as a steroid sparing agent. Now, azathioprine is a prodrug. It is metabolized in the liver to its active metabolite, that is 6-mercaptopurine. 6-mercaptopurine is further metabolized to 6-thioguanine. Now, this 6-thioguanine, it incorporates in the DNA of dividing T cells as well as the natural killer cells, and this inhibits differentiation of T cells and natural killer cells. Now, as we know, T cells play a key role in the pathogenesis of rheumatoid arthritis, and thus suppression of T cells, suppression of natural killer cells produces immunosuppressant and anti-inflammatory action. Now, adverse effects of azathioprine are nausea and vomiting. Nausea and vomiting are the most frequent side effects. Then bone marrow, reduced bone marrow activity, that is the myelosuppression, and azathioprine should not be combined with methotrexate, and allopurinol increases toxicity of azathioprine. So, azathioprine should also be administered cautiously only under the guidance of a physician. Another non-biological DMARD is the hydroxychloroquine. It inhibits activation of T cells. Hydroxychloroquine is used in milder non-erosive rheumatoid arthritis, that is rheumatoid arthritis not severe enough to cause destruction of the bone. It is also used in combination with other synthetic DMARDs like methotrexate and sulfasalazine. Now, let's understand mechanism of action of hydroxychloroquine. Now, as we all know, rheumatoid arthritis, in rheumatoid arthritis, healthy proteins of joints are attacked by the immune cells. Now, these proteins are termed as self-antigens. Now, these self-antigens are processed by the antigen presenting cells, and that further activates the T cells. Now, hydroxychloroquine induces lysosomal stabilization. Now, stabilization of lysosomes inhibits processing of these self-antigens by the antigen presenting cells. So, these antigens are not processed and these antigens are not assembled on the major histocompatibility complex. Thus, T cells are not activated. Synthesis of cytokines and further activation of B cells and macrophages is also inhibited. So, this is how hydroxychloroquine produces anti-rheumatic effect by inhibiting activation of T cells. Now, hydroxychloroquine accumulates in the tissues causing retinal damage and corneal opacity. It causes formation of maculopapular rashes, and rarely it produces cardiomyopathy and neuropathy. Next, non-biological DMARD is the sulfasalazine. Now, sulfasalazine is a compound of 5-aminosalicylic acid and sulfapyridine. It has modest efficacy and it is used as a second-line drug for mild rheumatoid arthritis disease. It is also combined with the methotrexate. Now, colonic bacteria in the colon split sulfasalazine into 5-aminosalicylic acid and sulfapyridine. Now, 5-aminosalicylic acid exerts local anti-inflammatory action in the colon, and therefore sulfasalazine is useful in ulcerative colitis, whereas sulfapyridine is absorbed systemically, and this sulfapyridine suppresses generation of superoxide radicals by the inflammatory cells, and also suppresses release of cytokines by the inflammatory cells, and therefore it shows therapeutic effect in rheumatoid arthritis. Now, adverse effects of sulfasalazine are nausea and vomiting, then neutropenia, thrombocytopenia. It can also produce hepatitis. It can produce hypersensitivity as it is a sulfa drug, and it may also be associated with low sperm count. Another non-biological conventional DMARD is the leflunomide. Leflunomide also inhibits proliferation of T cells. It can be used as an alternate to methotrexate. Now, leflunomide is a prodrug. In the liver, it is metabolized to its active metabolite, that is triflunomide. Triflunomide inhibits mitochondrial enzyme dihydroorate dehydrogenase. Now, this enzyme is required for the synthesis of pyrimidines by the activated T cells. Pyrimidines are further required for the synthesis of DNA and RNA, essential for the proliferation of T cells. This inhibition of this enzyme reduces synthesis of pyrimidines, further reduces synthesis of DNA and RNA by the T cells, and thus this inhibits T cell proliferation, inhibiting synthesis of cytokines by the T cells, and further inhibiting activation of other immune cells like the B cells and the macrophages. So, this is how leflunomide produces anti-rheumatic effect. Now, adverse effects of leflunomide are diarrhea, nausea, then headache. It can also produce rashes and hair loss, then thrombocytopenia, leukopenia, increased risk of chest infection. Long-term use can cause hepatotoxicity. It is contraindicated in pregnancy, lactation and children. So, this is all about conventional synthetic non-biological DMARDs. Now, let's discuss pharmacology of biological DMARDs. Now, since biological DMARDs can produce serious or fatal adverse effects, these drugs are used for refractory rheumatoid arthritis not responding to conventional non-biological DMARDs. Now, very important to remember that no two or more than two biological DMARDs should be used in combination. Now, let's first discuss pharmacology of tumor necrotic factor alpha inhibitors. Now, these drugs inhibit the action of tumor necrotic factor alpha. Now, as we all know, tumor necrotic factor is a inflammatory cytokine which is produced by the macrophages. Now, the first drug is etanercept. Now, look at this figure. It shows human immunoglobulin G. It shows the structure of antibody. Now, this human immunoglobulin G has two heavy chains. There are two heavy chains and there are two light chains. So, these are the two light chains. Now, region in the blue is the constant fraction, that is F constant, while region in the red is the variable region. So, this is the structure of the human immunoglobulin G. Now, look at this figure. This is the structure of etanercept. Now, etanercept is a fusion protein. Now, here the red color, this red color region is the tumor necrotic factor receptor, and this blue color region is the constant fraction of human immunoglobulin G. So, etanercept is a fusion protein made by the fusion of tumor necrotic factor receptor and a constant fraction of human immunoglobulin. Now, this drug etanercept, it binds free tumor necrotic factor alpha and neutralize it, and thereby blocking the action of tumor necrotic factor alpha. And this is how etanercept produces anti-inflammatory and immunosuppressant effect. Now, etanercept is the most commonly used biological DMARD, and its efficacy is similar to methotrexate. Now, the next biological DMARD is the adalimumab. Now, MAB refers to monoclonal antibodies. So, adalimumab is a monoclonal antibody. It is anti-tumor necrotic factor antibody, that is antibody that binds to and inactivate tumor necrotic factor alpha. Now, look at the structure of adalimumab. Its structure is identical to that of human immunoglobulin G1. Now, this is the constant region and this is the variable region. So, it is 100% human recombinant monoclonal anti-tumor necrotic factor antibody. Now, this is tumor necrotic factor alpha. So, adalimumab binds to tumor necrotic factor alpha and inactivates it. Now, it is the most commonly used biological DMARD, and its efficacy is similar to that of methotrexate. Now, another monoclonal anti-tumor necrotic factor antibody is the infliximab. It is a chimeral monoclonal antibody, and it consists of this is the structure of infliximab. It consists of 25% mouse and 75% human immunoglobulin G1. Now, this variable 25% region is from mouse, and this constant region, 75% constant region, is from human. Now, infliximab is the first tumor necrotic factor alpha inhibitor that became available, and it binds to tumor necrotic factor alpha and inactivates it. Now, since infliximab is a chimeral monoclonal antibody, its variable region is derived from the mouse. Use of infliximab can cause development of anti-chimeric antibodies, and these anti-chimeric antibodies can inactivate infliximab. Now, again, since it's a chimeral antibody, an acute reaction comprising of fever, bronchospasm, chills may occur on its infusion. So, this is all about infliximab. Now, let's discuss general side effects of biological DMARDs. Now, biological DMARDs produce prominent side effects more than synthetic non-biological DMARDs, and thus these are used as reserve drugs for refractory rheumatoid arthritis not responding to non-biological DMARDs. Now, there is increased risk of serious or fatal bacterial, fungal or viral infections. There can be reactivation of latent tuberculosis, development of malignancies like lymphoma, melanoma and skin cancers have been reported. However, connection between biological DMARDs and malignancies is not fully understood. Then rare adverse effects like neutropenia, pancytopenia, thrombocytopenia, congestive heart failure, hepatitis, hypersensitivity have also been reported. Now, after tumor necrotic factor alpha inhibitors, let's quickly discuss pharmacology of interleukin-1 antagonist and newer biological DMARDs. Now, interleukin-1 is a cytokine produced by activated macrophages, and the drug is anakinra. Now, look at this figure. Anakinra is a recombinant human interleukin-1 receptor antagonist. Now, anakinra, this is anakinra. Anakinra prevents binding of inflammatory cytokine, that is interleukin-1, to interleukin-1 receptors. So, this blocks the action of interleukin-1, and this is how it produces anti-rheumatic effect. Anakinra is clinically less effective than tumor necrotic factor alpha inhibitors, and it is also used clinically in refractory rheumatoid arthritis. Doses 100 mg subcutaneously daily. Local reactions and chest infections are the main adverse effects of anakinra. Another biological DMARD is the abatacept. Now, abatacept is a co-stimulation blocker. Now, look at this figure. This is a T cell and this is an antigen presenting cell. Now, T cells are activated by two signals, initial or the primary signal and the co-stimulation. Now, one of the signals is combining of major histocompatibility complex, that is MHC, with the antigen. This is the first signal. Now, besides this, co-stimulation of T cell is mediated by the interaction of CD80 on the antigen presenting cell with CD28 on the T cell. Now, abatacept binds to CD80, and binding of abatacept to CD80 blocks the interaction of CD80 with CD28. Now, this inhibits activation of T cell. So, activation of T cell is blocked by abatacept. Another newer DMARD is the rituximab. Rituximab destroys and thus depletes the B cells. Now, look at this figure. In the center is the B cell. There is a B lymphocyte. Now, CD20. Now, CD20 are the B cell differentiation markers. Now, rituximab, shown here in the yellow color, rituximab binds to these CD20 markers. Now, this binding of rituximab with CD20 causes destruction and therefore depletion of B cells. Now, destruction of B cell is mediated either by direct apoptosis, that is programmed cell death, or this binding causes activation of macrophages, that causes phagocytosis of B cells, or B cells are destroyed by the cytokines produced by the natural killer cells. So, this causes destruction of B cells and depletion of B cells. Now, destruction and depletion of B cells reduces generation of antibodies like rheumatoid factor that target the healthy joints. So, this is all about the non-biological and biological DMARDs. So, this is in brief pharmacology of anti-rheumatic drugs, a complete comprehensive overview. Now, please note that the information provided in this video is meant for students from their examination point of view. For treatment of rheumatoid arthritis, consult your physician. And if you find this video useful, kindly like, subscribe and share this video. Thanks for watching this video.